Okay, so I think I don't need to introduce myself since most of you are my friends. We are honored today to have two very distinguished speakers, Dr. Muhammad Abdel Badi' and Dr. Ramyun Malaziskin. Dr. Muhammad Abdel Badi' will be our first speaker. Muhammad Abdel Badi' is a specialist psychiatrist at Burjel Hospital in Al Ain. He completed his psychiatry residency in Al Khanka Hospital in Egypt, and then he worked as a consultant psychiatrist in Egypt, and he's also an international member of the American Psychiatric Association. Dr. Abdel Badi has a very long experience in forensic psychiatry and in managing patients in prisons. Dr. Abdel Badi will take us in a journey discussing the history and consequence of deinstitutionalization. So please join me all welcoming Dr. Muhammad Abdel Badi. Welcome, Dr. Muhammad.
Thank you, Dr. Muhammad. Assalamu alaikum. Thank you, Dr. Muhammad, for this nice introduction. And also I would like to thank the attendees and the organizers and Dr. Midhat Sabahi for giving me this opportunity. Today I'm going to talk about history and consequences of deinstitutionalization. This presentation was done before the pandemic, and I wanted to update myself to see what happened regarding this plan. Community-based mental health is one of the key objective plans of the WHO. Accordingly, millions of patients were discharged from psychiatric hospitals in the past years. On the other hand, there are reports showing up increasing number of mortality ratios of patients with schizophrenia compared to the general population, and an increase in suicidality, homelessness, and imprisonment among psychiatric patients. Therefore, deinstitutionalization is described by some experts as disowning the responsibility to decrease the high costs and funds for the mental health services. This is the WHO mental health model of care. As we can see, it is concentrating on the primary care mental health services, also in the community-based services. There is a good rationale behind integration of the mental health services into the community and in the primary health care. As you can see, the most important rationale is reducing the stigma for patients and their families. Also to improve the access of care and improving human resource capacity by allowing the GPs and non-specialists to work with the mental health patients. Also, it decreases the comorbidity by early detection of mental disorders in general patients and other disorders in our patients. Also, it improves the human rights protection. To understand and analyze the debate, I would like to quickly revise the history of asylums and legislations of mental health acts throughout the history. Then I will try to check how far the progress in the deinstitutionalization plan, and finally I will show some service quality measures used to evaluate this progress. As we know, in ancient Greece and Rome, the asylum was a place where those people persecuted could seek refuge, or including criminals and mistreated slaves and inhabitants of other states. These hospitals and legislations in the slide I consider them landmarks in the history of asylums. The concepts behind foundation and policy of administration of these institutes affected the successfulness and good reputation, or resulted in stigma of the asylums. Furthermore, the stigma of asylums affected the Mental Health Act legislation. First spot I will highlight the Bethlehem Hospital. Bethlehem Hospital was gradually transformed from small general hospital into a specialist institution for the confinement of insane. And it became the most infamous hospital in the continent for enforced segregation of inmates and abusive, inhuman treatment of the patients. Hundreds of patients were buried in the hospital graveyard, and the governors were shocked by the hospital status after the Great Fire of London, and transformed the location and, of course, the policy of the hospital. But still, the word Bedlam means roar and madman, and the stigma attached to the psychiatric asylums all over the world is still known. You can see a documentary in the internet about this hospital. It's very informative. In contrast, in France, from a gunpowder factory transformed to a hospital for containing the orphans and beggars, children, and ill women in Paris. Philippe Pinel is a French doctor and considered the father of modern psychiatry, worked on abolition and removing shackling of mental patients, and more generally for humanization of their treatment. The Salpêtrière became a center for neurological and psychological studies. Famous scientists worked there, and famous personalities have been treated in the teaching hospital of Sorbonne University. One of the legislation that affected asylums and institutionalization in the world is the Madhouse Act, which was done after Holy case. Holy had been committed to a madhouse simply in the word of her husband, who paid £2 every month for her board. And she was not able to leave the madhouse or communicate with anybody outside it. The act required that all madhouses be licensed by the committee of the Royal College of Physicians. By the way, she was able to get outside there after 2 months. This legislation also is a hallmark. The Community Mental Health Act, signed by President Kennedy in 1963, and the decision was based on several factors, including the high mortality and adverse effects of lobotomies done in the early 90s. And one of the victims was his sister. She was institutionalized because of failed lobotomy. Also, the deinstitutionalization movement and a famous novel about the asylums pushed the legislation of this Mental Health Act. The modern deinstitutionalization movement mainly coined or related to Goffman, who is a famed sociologist, coined the term total institution in his book about asylum's life. He viewed mental patients as guiltless prisoners, trapped within the institutions and segregated from the broader society. By the mid and late 90s also, the new medications improved some institutionalized patients and they returned to the community, but supporting the anti-psychiatry movement. Now we need to analyze how far the progress of the institutionalization plan. Actually, it is a very difficult question to answer, and there is no easy or not easy to measure how far this progress, because there is no single formula to measure or apply the plan until now. Therefore, despite decades of promoting the deinstitutionalization, mental health-based care still dominate the service delivery, consuming more than 70% of the entire mental health budget. And that in the low and middle income countries. And as a result, the mental health action plan extended till 2030. This figure showing the discrepancy of service between different countries. Some countries having 50 beds per capita, and some countries having 250 beds per capita. This figure also shows how difficult to explain the plan of deinstitutionalization. So, some authors find that results of deinstitutionalization, including the Penrose hypothesis. In 1939, in a cross-sectional study, English mathematician and a psychiatrist hypothesized that the number of psychiatric hospital beds and the size of prisons were inversely related. And again, this study were replicated in 2014 by Dr. Mendet in South America. Unfortunately, hundreds of mental health patients died between 2012 and 2017 after the NHS care failures. And as a result, also, the WHO extended the action plan for deinstitutionalization. One of the examples of the deinstitutionalization in USA, in the United States, during the pandemic, some psychiatric beds had been converted into general medicine for, or ICU beds to focus on COVID-19 treatment. As a result, the boarding time and number of psychiatric patients in the emergency showed threefold increase at least, until now. While the emergency department's visits for other medical causes declined during the early stage of the pandemic. The same results found in South Korea. There is an increase in overall crime and violence rates during the last 6 years after revision of the Mental Health Act. Also, in this systematic review on 106 publications for trends of psychiatric beds number, the results showed arguments about the high demand for psychiatric beds. Also, shortage of professionals, inadequate short length of stay, lack of community care. This small country in South Africa has the highest suicide rate per capita in the world. And despite that, the mental health, this mental health crisis, it continues without a national mental health response strategy. So how can we measure the quality of service? Also, it's a difficult question. The complexity due to different types of inpatients and bed needs vary from community to community. Also, there is a struggle to hire and retain behavioral health staff, especially for emergency and crisis service. These KPIs used to measure the quality of service in general. As you can see, one out-of-area placement, boarding in the emergency, the boarding length or numbers, occupancy rates, readmission rates, involuntary admission. In the community also we can check the homelessness rates and serious mental illness patients rates in the shelters. Also we can check the suicidal rates. So until now there is no single formula to know how many beds required for the communities. But a panel of 75 members answered structured and sequential questionnaires using a survey with controlled feedback as per the Delphi method. On this basis, the expert opinion was recommending a target of 50 beds for psychiatric service per capita. Also, computerized analysis used to determine the best psychiatric bed supply numbers, and the median number until now, what I found, is 40 beds per capita. These data I collect to determine which area to know might to be most effective on the in the suicidal rate in different countries. As you can see, this data collected from Economic Cooperation and Development Agency, and the numbers are totally not cannot determine where is the area or where is the problem affecting the number of suicidal patients in the world. Some countries having higher mental health beds, and some countries having psychiatrists more than others, but still this is not answering the question. So in conclusion, I can say that deinstitutionalization doesn't mean only dehospitalization. Mental health services should be wisely individualized for each community and integrated with general health services to reduce the stigma. Thank you.
Thank you so much, Dr. Abdel Badi, for delivering such a nice talk and for committing to the 25 minutes. Now we will have 5 minutes to take questions and discussion points from the floor. So, Dr. Mazin.
Thank you, Dr. Muhammad. It's a very nice talk, and it's very hard to collect all this data, I think. So you did. I just want to ask you. So we lost many beds during the COVID. You know that there is many sections in many hospitals had been closed. Especially, I'm talking about Rashid Hospital. That it was 50 beds, and we have been very stressed. In Al Amal, we have taken a lot of load. So I think Al Amal Hospital was covering like 8 million. So people, so we cover from Dubai up to Ras Al Khaimah. So we lost beds in Ras Al Khaimah, and we lost bed in Rashid Hospital. So we hope that in the coming days that we find many hospitals to open that beds. And the integration also of mental health people, that now they are talking down to primary health care. So to prevent the people from coming even to the general psychiatric hospital or to the general hospitals. And the boarding also, I think it's a very big problem, especially if you are working in a hospital, general hospital. So whenever they have psychiatric patient, they will put stress on the psychiatrist to come take their patient or discharge them home. It will be a closed neck. So we are facing a lot of problems. Are you aware about any statistic of psychiatrists in Africa region or other countries? Because I see that it's only European statistic, I think.
This organization, I found the data on only containing 50 or 40 countries. Most of them are developed, but there is no recent data about the number of beds from our region. But I think we have shortage. Yes, it is not compared to the numbers recommended in the studies I showed, which is 50 or 40 per capita. So I think we have shortage. We need to improve the numbers.
There are some countries they don't have psychiatrists at all.
Yeah.
So they travel to some countries just for the medical care.
The highest,
Unfortunately, yes.
yes, the highest suicidal rate in the world for a long time in an African country, one of the African countries. Yes.
Any other question? Comment? Discussion point?
But I also want to add that not only the number is the important, the quality of service, because many of our countries, for example in Egypt, having too many beds occupied by chronic long-staying patients, boarding for no follow-up, revision of treatment, and so on. So it's also not good to make a huge number of beds without good quality of service.
Any question? Since questions are not ready yet, I will take this opportunity to ask you a question, Dr. Abdel Badi'. I know that you have a very long experience in forensic psychiatry, and from your experience, recently, especially in the UK, there have been a back movement from decentralization to centralization of the psychiatry service. So I need to your comment and your thought on this. Would you please expand on this? What do you think about decentralization and centralization of the psychiatric service? I know, as you write here, deinstitutionalization doesn't mean necessarily dehospitalization. Would you expand on this, please?
Yes, actually, my internship and early training was in a forensic department, and I can tell that many of the patients that reached the prisons and forensic psychiatry departments reached because of poor service, and they didn't find the necessary treatment. If they were treated well, they were not admitted. Many of the inpatients, including drug abuse patients, but also psychiatric patients and serious mental illness patients, admitted due to prisons or the forensic departments in the hospitals because they didn't have the service.
Okay, thank you, Dr. Abdel Badi' once again. And our next speaker, who's the current president of the Lithuanian Psychiatric Association, was supposed to join us virtually. Unfortunately, we have difficulties connecting her. So this will be our intake for today, for this session. Thank you, Abdul Badi, once again. And I think we will move to the next session. Thank you so much.